Welcome to your USMLE Study Buddy. Hi, this is your Study Buddy, Dr. Dio, and today's highlight topic is myocardial infarction. So this is one of a review series where I will review only the highlight points of highlight concept, highly tested into the USMLE exam. So grab your pen and paper and grab your coffee and your entire attentions just to review, just to check that whatever high point I am highlighting over here, you are already done with them. So number one high point of myocardial infarction is the gross macroscopic feature. You can see over here is a picture of gross macroscopy of old versus new myocardial infarction on cardiac tissue. We need to be able to identify the old versus the new infarct. And yes, the type of necrosis in myocardial infarctions of a cardiac tissue happen is coagulative necrosis. High yield point number 2, the predominant microscopic feature. Yes, while solving the URL, we have seen this chart, and I hate to say that, yes, we have to memorize this whole chart. But let's make this a little bit easier to memorize. You can see in this timeline of 1 to 3 days. 1 to 3 days is neutrophil, 3 to 7 days is macrophage, and 7 to 10 days is the beginning of the granulation tissue formation and end of the phagocytosis by macrophage. If you can remember this 3, then you can easily remember that after 2 weeks, the formations of mature scar begin, and after 2 months, 2 weeks to 2 months, the mature scar formation is done. One thing about neutrophil, I want you to remember that after phagocytosis of dead myocyte, you can see that it is secreting the lysosomal enzyme, reactive oxygen species, and two very important cytokines. One is interleukin-1 and tumor necrosis factor alpha. But in case of macrophage, the secreted cytokines are interleukin-10 and transforming growth factor beta. Speaking of transforming growth factor beta and interleukin-10, it's very important for formations of the granulations and also the maintenance of also reducing the inflammatory process. So interleukin-10, the functions of cytokine interleukin-10 and transforming growth factor beta is very high. Speaking of scar, there will be correlations from general pathology. For example, where there is scar, there is fibrosis. Where there is fibrosis, there will be extreme depositions of type 1 or type 3 collagen. But in mature scar, there is the type 1 collagen predominance excels. In post-MI, what type of collagens are most dominant? It is type 1 collagen. I have also included another video where I have discussed the mnemonics and also the example of collagen types and the clinical associates so that you can memorize this easily. Topic number 3, the coronary artery related clinical implications. For example, to be master in it, you must make sure that you know the origins of arteries, coronary arteries, and also the course of coronary artery and the area that supply the blood. For example, right and left coronary artery arise from the aortic root, and from them right coronary artery goes downward and backward and and also giving blood branches to the right ventricle, and then also give branch to the SI node. Giving blood supply to SI node, the origin of the blood supply of SI node is coming from right coronary artery, and this point is very high. Speaking of left coronary artery, in case of left coronary artery, you must know the branches like left anterior descending artery, the circumflex artery, the diagonal branches when it goes backward in the posterior wall into the atrioventricular grooves, and then it converts, and sometimes it gives branch to interventricular groove, where as a posterior descending artery. but posterior descending artery mostly coming from the right coronary artery, because most of us having the right coronary artery dominance. So when you are done with the reviewing gross anatomy of the coronary artery, its course or its origin, the structure, the supply, you must notice the ECG configuration. Not going to break down how the ECG basic principle work, but all I want to say that you must know the configurations of augmented limb leads, bipolar limb leads, and the chest leads. You must be able to identify the inferior MI, the posterior wall MI, anterolateral MI, the circumflex, left circumflex artery, left anterior descending artery, and also the whole coronary artery block finding on ECG. So ST segment elevation and ST segment depressions are two main finding by which we actually differentiate the myocardial infarctions from angina. So it is very important to know and to understand the ST segment elevation, the ST segment depression. When ST segment elevation happens, that means it's a transmural infarction. Transmural means the whole myocardium, whole endocardium, myocardium, and the visceral layer of the pericardium is involved. And if it is ST segment depression, that means this just subendocardial ischemia is happening into the heart. You also need to know that Q wave significance. What does Q wave mean? We all know that pathological Q wave defines all MI. Now, another important topic is the post-MI complication. What happened into the post-MI complication? One of the most highly tested topic of post-MI complication is cardiogenic shock and obstructive shock. High yield topic number 6. Over here, they want you to know when in a cardiac myocyte, if there is sudden block of blood supply, what happened within 1 minute? What happened after 30 minutes? What happened when there is reperfusion before 30 minutes? In case of, in a cardiac myocyte, which is getting blood supply, suddenly that blood supply got blocked. Within 1 minute, the cardiac myocyte will stop contracting. Second of all, if the reperfusion is established before 30 minutes, there will be reversible injury. But this injury persists more than 30 minutes, that means this is irreversible injury. Topic number 7 is myocardial hibernation. Well, this topic is more into understanding rather than memorizing, and I would love to give you the UWorld question ID over here, so that if you really want to understand the whole topic, the explanation of UWorld is more than enough for it. High yield topic number 8, the post-MI complication. We need to be able to identify or differentiate what type of complication is happening by simply looking at the question vignette, whatever sign and symptoms the patient is exhibiting. I know this chart is a little bit of frustrating, but let's make this easier. If there is right heart failure, and if there is ventricular free wall rupture, you will see to lung filled. Okay, if there is no congestion, both of them never have any congestion. But in between these 2 points, the papillary muscle rupture or the interventricular septum rupture, in these 2 points there will be pulmonary congestions, heart failure symptoms. Okay, the lung will be involved. But if it is the right heart failure, or if it is the right ventricular free wall rupture, or ventricular free wall rupture, or left ventricular free wall rupture, then it is there will be no involvement of lung field. Lung field will be clear. To differentiate right ventricular heart failure and ventricular free wall rupture, just simply look at the timeline. Now, if we see that post-MI, there is an onset of new onset of holosystolic murmur, and there is a high chance there will be a papillary muscle rupture, or there will be high chance of interventricular septal ruptures. Just to identify just to differentiate, we need to see we need to do oxygen saturations of both cardiac chamber. If it is even, then it is interventricular septal rupture. And if there will be chest pain in interventricular septal rupture, biventricular heart failure in interventricular septal rupture. But if you can see the left ventricular apical aneurysm, this situation is a long-term consequence of post-MI. For example, it will just look at the timeline, 2 weeks, between 2 weeks and 2 months, and aneurysm will happen if there is the post-MI complications continues after within 2 weeks to 2 months. Then it is left ventricular aneurysm, and patient will exhibit subacute anginal pain, chest pain, etc. High topic number 9. You must be able to identify or differentiate between the myocardial infarctions, stable angina, unstable angina, and prismatal angina. And in that case, just look at the ECG, look at the age, look at any risk factors of using any drugs like cocaine. And if you can see that there is ST segment elevation and it is not relieved by nitrate, then yes, it is a myocardial infarction. But if it is ST segment elevation, depression, there is a high chance that can be stable or unstable angina. And stable, and to differentiate between the stable and unstable angina, just give the nitrate. If it resolves, then it is stable. If it doesn't resolve, this is unstable angina. In case of prismatal, it is totally genetic. There will be smooth muscle hyperactivity of coronary vessels. Over here, there will be vasospasm. You can get easily confused with prismatal angina and angina induced due to the cocaine abuse. So in case of prismatal angina, you look at the age. The age is relatively younger people having this type of angina. And in cocaine abuse too happen. We see that happening into the younger age people. But just look at the eye. If the pupil is dilated, then yes, there is a high chance it is cocaine abuse. And also look at the pressure. If the blood pressure is higher, then yes, there is a high chance with cocaine abuse. Okay, if it is prismatal angina, the patient will be, if you look at the lipid profile, you will, or if you check if there is any evidence of atherosclerosis, you will find none. Topic number 10. The right coronary artery block and what happened to the hemodynamic profile. So it is very important when right coronary artery get blocked. You know that the synodal artery is originating from the right coronary artery. If the entire right coronary artery is blocked from the beginning to end, then there will be sinus bradycardia, and also the consequent area which are supplied by the right coronary artery will get blocked. Highest topic number 11. Why right ventricle is protected than left ventricle in post-MI. So you can see this chart. This chart, yes, we need to understand it. It is more into understanding rather than memorizing. And I will be giving you the question ID of URL so that you can study that portions with the differential diagnosis. This is very important for understanding, not just for memorizing. Hi, topics number 12, the indications of percutaneous coronary interventions, when it is done and why it is done. Title topic number 13, why there is pain in myocardial infarctions. The main pain mediator is adenosine. In myocardial infarction, there is increased level of adenosine because all the ATPs are depleted and there is increased concentrations of adenosine which goes irritate the free nerve endings. So the final topic is cardiac marker. So cardiac marker, we must notice the troponin I level. By troponin I level, we should be able to identify or differentiate whether it is a short MI or it is a long MI or the recurrent MI. Just to see whether there is a recurrence of MI, we must look at the CK-MB level. You should be able to differentiate the myocardial infarctions from the stable angina, unstable angina, prismatal angina, who can abuse vasospasm. And for that, you just look at the ECG, you look at the age, you look how the patient react with the sublingual nitrates, and also look at the pupil, the blood pressure, just to make sure that you are diagnosing myocardial infarctions perfectly.